I'm very happy to be here today. I'm opening my slides now. I have the pleasure of working in the same institution with Eric, which always leads to lively discussions on actual themes within psychotrauma research and well, the response to events. Eric already explained several of my affiliations. Actually, they are quite. I'm linked to quite a number of organizations. That means that I'm physically attending several locations in the Netherlands constantly. I'm always traveling. Now I'm in Groningen. I think the red thread of my work is mostly linked to trying to understand the mental and health, physical safety and health impact of all types of events in the Netherlands, but also in other countries. And also, especially, which I think is an even more complex question, to understand what is an adequate, optimal response from governments, civil society, citizens in dealing with the impact of events like that. Today's topic carries the title, is the existing disaster mental health knowledge base applicable to COVID-19? And when I formulated that, I thought, well, it is quite a heavy title because while preparing for this talk, I could realize I can talk for hours about it, but I only have been given 20 minutes and I already used one for this playing with the first slide. So let's quickly continue with the next one. Well, the world in which we live globally is a source of all types of risk, of course. And I randomly took two overviews of risk maps we have, and there are multiple more. You can think of terrorism maps or sea level maps. The map shown on the left shows, it's taken from the World Risk Report. It's an annually updated report with information on risk to natural hazards, as well as the capacity of countries to deal with that. And what you can clearly see is that the risk is not distributed equally across the world. This also applies to the map on the right, which is more about security and political risks. So essentially, we are living in a world full of risk, and the prospects are not that positive if you would think of it. We have population growth, globalization, climate change, exhaustion, scarcity of all types of resources of water. We have migration waves, refugees looking for safety, a better future, pollution, decreasing biodiversity. So if you look at the world in which we live, there are a lot of things to be worried about. Today, what I wanted to do is, I divided my talks in two main parts. The first one is about going deeper into what is the existing disaster mental health knowledge base. And it roughly can be divided in epidemiological knowledge on health and risk issues, and also guidance, guidelines, recommendations. And the second part is, what did we do so far globally in the context of COVID-19? What do we know about the mental health impact? What was done? And what can we learn from evaluations? And I want to end this talk with some reflections. Well, there is really a ton of literature on the mental health impact of disasters and all types of events, terrorist attacks, landslides, traffic accidents. Well, there's more. We can talk for hours about this topic in itself. But in short, what we know from the literature is that exposure to any type of event, direct exposure, additional losses is just not good for you. But we know that this contributes to a probable increase in post-traumatic stress disorder, mood and anxiety disorders, substance abuse, dependence, suicidality, physical symptoms and conditions, social problems. And this is only, actually the studies shown here, they are nice works that give you an indication of what can happen to you when exposed to a disaster. We also know about patterns over time. I can really recommend this Bonanno and colleagues' work from 2010. It's about showing over time, after the initial peak, how slowly all types of health problems decrease over time. We're also working on long-term reviews at the moment, but they are not really at the point of being published yet. So perhaps in a later talk, we can go deeper into that. It's important to emphasize is, although we know a lot about the impact, the health impact of various types of events, many of the studies suffer from methodological problems. We often don't have good pre-event or baseline data. Comparison groups are often a bit biased or flawed, of overrepresented with particular groups. And there are various sources of bias in the selection, the instruments used, and well, this is also something we always must keep in mind when we read new studies about COVID-19. I will go deeper into that later, but I could not complete this slide without referring to some of my hobby projects. And that is, I'm really interested in how the epidemiology of mental health looks like across the world. So from recent decades, several research groups produced information on the prevalence on PTSD, depression, suicide in different countries. And what we know from those studies is that there's a lot of variation in the natural, if you would call it like that, baseline of a country. And what we know that a disaster will come on top of that. So you must understand the baseline to be able to say something meaningful about how big is the impact of an event. And what I really like, the studies I really like go a bit further, and they are trying to about understanding the baseline itself. And we know from several studies so far that the baseline, the prevalence of mental health disorders is linked, of course, to trauma exposure. And this is replicated several times, as well as cultural and socioeconomic country characteristics. So this really shows that in our disaster research, in trying to understand the impact of a population in a given disaster, we must also look at the particular cultural and socioeconomic profile where the disaster takes place. What we also know from epidemiology, which is, I consider this a really important part of our knowledge base, is that we know a lot about risk and protective factors. We know that they differ through time stages, and we know that our pre-event determinants, this is like more the social demographics of a society, yeah? Sex and gender, gender and age, I should say, ethnic background, the level of social support you have, the socioeconomic status, your existing health profile. But what we know at a certain moment when the disaster takes place, then the exposure to death, destruction, fear, all these things matter as well. And also the extent to which it's nearby or more distant. And later on in the recovery phase, especially in the beginning, this phase is characterized by a lot of social support in society. People trust each other and also have some good hopes about the future. But a risk factor here is that there are additional losses. There are things that are important to you in terms of relations, possession, housing, positions you have. And later on, this is a typical phase we call the disillusionment phase. We know it will get more complicated because people lose their patience, feel ignored, feeling neglected. Often problems are not solved yet, and these are all typical risk and protective factors that play a role in the life course of a disaster. And then, of course, we can make a distinction between, very briefly, in different levels, the factors that are more linked to the individual, factors that are linked to the communities where we live and the capacity of communities to deal with problems, and societies that can differ tremendously in the quality of healthcare systems. And Lisa in her talk will go deeper into that, how different healthcare systems are actually linked to the nature of psychosocial support provided after terrorist attacks. So in the end, you could say a poor healthcare system is a risk factor in itself. But I can mention many more examples, but I won't do it now because of time. Guidance. We can expect a lot of things about disasters and how they will affect us. But the crucial question is, how should we deal with them? And in order to answer that question, many international initiatives have been taken to develop guidance, including under the umbrella of a NATO working group together with Irina, Joseph, and Eric, especially linked to the golden hour. And guidance implies that it gives us information on how to act, that it contains practical recommendations on what to do, inspired and fed by scientific evidence, as well as practical wisdom. Which brings us to, there have been many initiatives, like I said, combining scientific evidence and practical wisdom. And often these documents, these guidelines, guidance documents, toolkits, they can frameworks, they can carry several names, of course. They are in fact ideas, principles, recommendations that should be helpful for people in practice to aid people in need. And all these documents have limitations, but they are undeniably viable as a frame of reference when a disaster strikes. What we on the forehand, it's obvious that many experts agree on the fact that we will never have the scientific evidence we really need and really want to have to support the guidance we produce, because some things are very difficult to research. And I know that, for instance, I will mention several examples later on that already start in the introduction with, since we will never have the information we really want, what we can do is at least use the scientific reviews we have and the consensus among the best experts in the world to at least reach agreement on recommendations. So many of the guidelines worldwide are actually expert-based consensus documents. So that the strength of it is that you can really, across country borders, look for patterns on what we think is important for people affected by disasters in different contexts. But it's a disadvantage that there's always a risk of groupthink. So we should always be very open in discussions we have with experts on when we formulate guidance. So this is just an introduction. Recently, some colleagues of mine at ARC, we completed this analysis of more than 10 international guidelines, and we scored them using the AGREE instrument. And what you can see here is on the left, AGREE scores. That's a methodological quality score for different guidelines. On the left, and we rank them from high to low. And what you can see on the right are the different domains of the instrument. And the idea is that at least 2 to 3, and in some cases we did 5, people independently go through a document and assign scores to the various domains you can see on the right. And then an average is calculated. And if you add up the averages, then you can get a total score like shown on the left. And so in this review, we looked at, is the topic clearly described? Is it clear who the participants are? Which methods were applied and how varied they were? What was the nature of the recommendations itself? And also the implementability. And I think it's already interesting in itself to see that so many of these valuable documents apparently vary greatly in their quality. And this obvious, you can all imagine, like a dimension such as implementability. That's a crucial one, because in the end, if we are not capable of translating the contents of our projects to real life disaster situations, then they cannot meet the potential they have, I would say. So I'm just showing this, that we have a lot of guidance, but we should also be very critical about our guidance. And what we did is the next step. The 4 guidelines with the highest scores, we analyzed their contents, and we clustered that along different domains of psychosocial support, if you would call it like that. And the domains, the categories we distinguish are basic relief, information, emotional and social support, practical support, mental health care, and monitoring eventually came out as a rest category. And what you can see is that many of these guidelines, they have different numbers from 1, 2, 3, and 4. There's also, for many recommendations, you see a lot of overlap. And I think that's a good thing, that apparently there's also consensus among the guidelines about what needs to be done. And to give you an example, the basic relief, of course, is about very basic things in life that you want people after a disaster to have, like food and water and medication and housing and, well, safety. Information is often to do with psychoeducation, information about the event itself, and several methods are provided, and that's where it gets more practical, like organizing meeting or leaflets that can be written. And well, it goes too far to mention everything in this list, but at least this gives you an indication of our, what I would call, current knowledge base of disaster aid. And what is also nice, if you go through the the guidelines, the guidance, that you can see that there are recurring themes. Like this is the famous 5 essential principles from Stephen Hopful and colleagues. Like the idea that's more like an imperative, that we should all strive at promoting a sense of safety, calming, self and community efficacy, social connectedness, and hope. And in another, the IASC triangle from the set of guidelines, that really gives an overview of how a stepped care system should work, and that only a relatively little portion of the affected eventually needs specialized clinical mental health care, while most of the population benefits from basic services and security, community and family support, and that there are always different types of actors involved in providing those types of services. So that's really like a model that can help you in your planning. Same applies to this model by Bertolt Gersons. We call that the circle model. And the idea is also in stepwise care that in the center is the person affected, and there are different circles around a person. And every circle more to the outside is indicative for an additional set of specialized care. Initially, we find a lot of support from our inner circle, from family and friends. And then you can go to a more organized setting of people nearby, close to you, but that's not part of the formal healthcare system yet. That's more where we find primary community care, social work, and if necessary, you can be referred to more specialized mental health care providers. So this is essentially a complementary model to the circle on the left, or at the triangle on the left, I should say. And another model I would like to show is, this is something we often don't make explicit, but we all say you should provide adequate support, but your attitude matters. And there's no good or evil in it, I think, but the most important thing is that you don't cross the thresholds. So it's good to wait and assume that people are resilient, but at the same time, we know from epidemiological research that not everyone is. So we should be very careful to make sure people don't fall through the cracks. Because if that happens, then you are too passive. And the other way around, I think it's very good and also a token of the fact that you care to be proactive towards populations, but you should not go too far and not like offer things people don't need and create waste, and even provide disputable interventions such as psychological debriefing, which is not recommended in any of the leading guidelines at the moment. So in a nutshell, that is a summary of the what I would call the current knowledge base of disaster mental health. And obviously it's not complete, and I'm really struggling to keep it in the timetable of this meeting. I would now would like to go to the second part. COVID-19, the pandemic that surprised us all, I think, in the beginning of next year, and in Asia, the end of 2019, of course. The mental health impact. Well, what we all have seen as researchers is that an astonishing amount of research and publication was produced in the initial months of the pandemic and the year after. And most of the tone in these documents, especially in the beginning, is one that expresses deep concerns. And also based on what we know from disasters. And then you find understandable conclusions such as the COVID-19 pandemic has alarming implications for individual and collective health and emotional and social functioning. And also from this one, a nice paper in Lancet Psychiatry, it is already evident that the direct and indirect psychological and social effects of the coronavirus disease pandemic are pervasive and could affect mental health now and in the future. And what I also like is what Horton wrote in his editorial in Lancet last year, speaking of a syndemic. And that's really the point where a more biologically and individual health focus should really be combined with the idea that a disease only exists on a background of economic and social disparity. And I have a lovely quote about this, but that would take an entire slide. But it really shows you that we cannot approach this problem without looking at the deeper social demography of society with all its risk factors in it. So, indications of mental health impact in the first months and year of the pandemic, a plethora of studies and reviews. I collected more than a dozen of reviews that all indicate at increases in anxiety and more like depressive disorders. But there's also a problem with it, because if you look honestly at all those studies, they are heavily flawed often, with biased samples, often cross-sectional, lack of proper control or comparison group, don't have pre-event baselines, and there are many limitations, which, well, although based on face validity, I think we all agree upon the health risk, the mental health risk linked to COVID-19. But if we look at the material there is, as serious scientists, we should always remain critical. I know one of a really good study I read contained pre and post corona panel studies, and it had multiple measurements. And what you could see is that through different age groups, the only people who really developed more anxiety and depression symptoms were those who felt more lonely. And I think that it tells us a bit more of the story, that people suddenly became lonely during the pandemic, which is very understandable given all the heavy measures taken, that a measure like that really influences your health. What was recommended during the COVID-19 pandemic? Well, recently a paper was published. I think it was Lancet Global Health or Lancet Psychiatry by Kola and colleagues, and it is an overview which shows you that in the first months of the pandemic, that many valuable guidance documents were created, and it goes too far to list them all. But the IEAC also produced an excellent general disaster mental health guideline, also made a specific adaptation for COVID-19, and that was already available freely worldwide in the beginning of the pandemic, or in the early months, I should say. And the graph shown here shows that there were also specific documents made for countries in Africa, for instance. And what they also did in that paper is show good examples of more remote services and in-person services, and they were categorized into health-seeking and delivery of treatment services, detection of psychological distress and mental illness, mental health and psychosocial principles in the COVID-19 response. And well, you can see examples like phone-based screening, remote family services, primary care centers, addiction management and prevention. Well, if you start looking at what's available internationally, it's really impressive and remarkable. And unfortunately, I think many of us don't have the time to do it, but if you had the time, I think you would all be amazed. And this also applies to the next one. I did this systematic review I recently discovered, and I'm really impressed by it. It's from Damiano et al., published in August, I think in Depression and Anxiety. And what they did, they really did a systematic review of all types of interventions carried out during COVID-19. And my apologies for the fact that the font is so small, but I was really struggling to get it on one page. And they categorized the interventions in psychological, psychiatric interventions, complementary and alternative therapy, self-care, technology and media, education, governmental programs, general recommendations, spirituality and religiousness, healthcare institutions, and physical intervention. Well, it's really an amazing paper with good examples and many references for each of the things shown here. I left them out just to make sure that it would not be too much. So this is, I think this gives a good overview, and it's an excellent read for everyone. And well, there comes the point, we want to learn whether it helped. And this is where it gets complicated, because the previous two slides give an overview of different good examples and interventions. But in order to use those insights to strengthen the current knowledge base, we need evaluation studies. And then the problem is, this is also from the study I showed you one slide before. In this particular review, They looked at 2,800 studies and included 125, including 3 RCTs. And what they conclude is, well, we found a large body of expert recommendations that may help health practitioners, institutional and governmental leaders, and the general population cope with mental health issues during a pandemic or a crisis. However, most articles had a low level of evidence, stressing the need for more studies with better design, investigating potential mental health interventions during COVID-19. And yes, and that's also why I chose the title Evaluation, a Necessary but Often Neglected Job. I think collectively we are not good at it in allocating resources to carefully evaluate what the results are of the interventions we apply, of the services we provide. And this is also one of my hobby projects, but it should be more than a hobby project, because in the end, we really, in my view, we really need to learn more and also be careful in the studies we write about what the working mechanisms of interventions are, the conditions where they are implemented, what plays a role, why does it work here or not, and what complicated matters when we try to provide services, that type of information. Because if we don't understand that, it really hinders us in the effective broad uptake and scale up of good practices. I wrote a paper on this earlier this year in Intervention, and I want to be very careful with personal advertising. But if you are interested in this topic, there's a lot more to find in there about complications in evaluation models. Well, if you're interested, look it up. Reflections. I'm now entering the final part of my presentation. Well, I think it's quite a challenging question, huh? A bit provocative even. Is the exhausting disaster mental health knowledge base applicable? I would say yes. I really think also, as I am personally involved in shaping the crisis approach in the Netherlands, and I talked with a lot of colleagues internationally about their experiences, I really think that the existing knowledge base was helpful to structure, align our thinking and discussion within and between country borders, or across country borders, I should say. I also really believe that the existing epidemiological knowledge helped us to identify risks and also to express concerns. And I also think that the existing guidance, all the documents that were there, was a good starting point to rapidly produce more pandemic-specific recommendations. And finally, for this slide, I think the existing guidance was useful for the planning and delivery of support and healthcare interventions at collective and individual level. If I had more time, I could also tell you a bit about what we did in the Netherlands. It's a combination of interventions that actually fits very well within the Lancet overview of the previous slides, but it goes too far. So when it comes, the answer to the question is partly a yes, but it's also a no. Because if we honestly look at all the material, most of our disaster findings are clearly based on different types of events. We don't have that in the modern time. We don't have that much literature on slow onset, creeping crisis, slow moving events, and that in this case are not really lethal for the population as a whole, but especially dangerous to the vulnerable, especially the elderly. What we also see is that this type of event has a different intensity of trauma exposure, if you would call it like that. The literature is less occupied with chronic uncertainty and stress. And this, I think, is mostly relevant from a clinical psychological perspective. Well, approaching mental health risk of COVID-19 from a psychotrauma perspective is problematic. I've seen several studies so far, and this from Norholm et al. Was also recently published. And these authors drew the conclusion that the application of a more liberal interpretation of criterion A, which is how you look at exposure and the impact of it, will dilute the PTSD diagnosis, increase heterogeneity, confound case control research, and create an overall sample pool with varying degrees of risk and vulnerability factors. Well, again, there is so much interesting stuff out there to read. So at least I'm taking this with me now just to emphasize that we should be very critical about applying the existing knowledge base on an event like this. I also have the feeling that it led to an overestimation of short-term population impact. And in some of the newspapers, TV shows, and also in serious academic journals, I read a lot of papers that, well, I find them rather alarmist and activistic, and undoubtedly inspired by good intentions, but we should also be very careful with the awareness we try to raise. An important thing also, we don't know the effect of the health measures and interventions. So that's also is why we should be very critical. And finally, this is also linked to the guidelines I already showed you, the overview with scores. When it comes to COVID-19, I think that the methodological shortcomings and universalistic nature of the recommendation does complicate the application of guidance in unique population context, because these recommendations are often very general, and you should also be very critical about what does this mean for us here, for particular groups, particular professionals at this moment in time, under these circumstances in this type of healthcare system, well, all these context variables. And that is actually the final sentence of my last slide. Thank you very much for your attention. And I'd like to acknowledge some of my colleagues who provided invaluable work to fill the slides here. Thank you.
Now, thank you so much, Michel, for a brilliant talk with so much information, a high density of information. Thank you for sharing that and dividing it into a part 1 and a part 2.